Well, welcome everyone. I see a few more people trickling in, but we're going to get started with our session this afternoon, Vaccines Boosting Confidence. I'm Priscilla Valencius from Merck, and with my colleague, would you introduce yourself?
Katie Anderson from Pfizer.
We are really looking forward to moderating what should be a great session focused on methods for assessing vaccine effectiveness for COVID vaccines. A couple of brief housekeeping items. It has been strongly requested that we hold all talks to the planned start and stop times, and this will include 10 minutes for the speaker and 5 minutes for questions. There is a mic in the aisle. For those who have questions, if you can plan to come to the mic and introduce yourself with your name and institution, that would be great.
Our first speaker will be Rachel Ogilvie, the effectiveness of BNT162b2 COVID-19 vaccine in U.S. children aged 5 to 17 years.
Good afternoon, everyone. My name is Rachel Ogilvie, and I'm a senior epidemiologist at Optum. And on behalf of the FDA BEST initiative, I'm pleased to present our work on the effectiveness of the Pfizer BNT162b2 vaccine in children aged 5 to 17. These are my disclosures. The primary objective of our study was to assess the effectiveness of receiving the complete primary series of the Pfizer BNT162b2 vaccine in preventing 2 COVID-19 outcomes in children aged 5 to 17. This was an observational cohort study conducted in the Optum pre-adjudicated claims database linked to the immunization information systems in 10 jurisdictions. Patients were required to be age 5 to 17 at cohort entry. The study period for this study began on December 11th, 2020, when the Pfizer vaccine was first approved, and ended at jurisdiction-specific end dates, with the latest being May 31st, 2022. The exposure in this study was the Pfizer BNT162b2 vaccine, which was the only vaccine approved for children during the study period. All vaccinated children were identified at their first COVID-19 dose, and the date of dose 1 was assigned as time 0 in these children. Then, unvaccinated children were matched 1-to-1 with replacement on calendar date, age, sex, geography, immunocompromised status, history of COVID-19, pregnancy, risk of severe COVID-19, and receipt of a flu vaccine within the past 365 days. The calendar date of dose 1 for the vaccinated child was set as time 0 for the matched unvaccinated child. You can see the inclusion and exclusion criteria here in this orange box. All children were required to have at least 365 days of continuous medical and pharmacy coverage, or coverage back to the age-specific vaccine authorization dates, whichever was longer. All children were also required to live within one of the 10 IAS jurisdictions. Patients were excluded from the study if they had a code for convalescent plasma or monoclonal antibodies in the 90 days prior to time 0, a diagnosis code for COVID-19 in the 30 days prior to time 0, rash, fever, nausea, vomiting, an hospitalization or an emergency department visit in the 3 days prior to time 0, or if they were hospitalized or in long-term care residence on time 0. You can see our 2 claims-based outcomes listed here. These were both identified by the U071 ICD-10 code. These included medically diagnosed COVID-19 in any setting and hospitalized ED diagnosed COVID-19. The recorded date of the first diagnosis code was assigned as the outcome date. Covariates in this study were assessed on or before time zero using enrollment, diagnosis, procedure, and pharmacy codes. And these included measures of descriptive characteristics, frailty, healthcare utilization, and conditions leading to a higher risk of COVID-19. Both vaccinated and unvaccinated children were followed from time zero until the first occurrence of a COVID-19 diagnosis, end of the study period, disenrollment from the health plan, or deviation from the vaccine schedule assigned as time zero. For vaccinated children, this deviation was defined as receiving the dose 2 before day 17, as indicated here on the figure. Was defined as failure to receive dose by day 42, as indicated here on the figure. Receipt of any other brand besides Pfizer, and or receipt of the third dose of the BNT162b2 vaccine. For unvaccinated children, deviation from the vaccine schedule assigned at time zero was defined as receiving a first dose of any COVID-19 vaccine, at which time they were censored and allowed to join the vaccination group. Here is our analysis that we used in the study. We used propensity scores estimated with multivariable logistic regression models, and these models included all of the matching factors and covariates. We then used the propensity score to estimate stabilized inverse probability of treatment weights, and these were truncated below the first percentile and above the 99th percentile of the propensity score distribution. We then used these weights in Cox proportional hazard models and estimated 95% confidence intervals with robust sandwich variance estimators. In this study, vaccine effectiveness was defined as 1 minus the hazard ratio. We had several sensitivity analyses in this study, the most important of which is the simple exposure misclassification quantitative bias analysis. And the goal of this analysis was to estimate the impact of truly vaccinated children being misclassified as unvaccinated because of missing vaccine records. To do so, we generated a 2x2 table and risk ratios from a weighted log binomial analysis using fixed follow-up time. We then obtained estimates, bounds of sensitivity at 71 and 83% by comparing each jurisdiction's vaccine coverage estimates to age standardized estimates from the CDC, state departments of health, and capture-recapture methods. A bias correction factor was calculated and applied to the original hazard ratios to generate an estimate of vaccine effectiveness corrected for exposure misclassification. We also had several other sensitivity analyses, including subgroup analyses stratified by age and variant era. And as part of this study, we also performed negative control and informative censoring analyses, but I won't be discussing those today due to time. So here's an abbreviated version of our flowchart. We have 394,674 patients aged 5 to 17 in the 10 IAS jurisdictions. And after applying the eligibility criteria and matching, we had 92,338 patients in each exposure group. This is an abbreviated version of our table 1. You can see in the orange box our absolute standardized differences, indicating that after matching and weighting, these cohorts were very well balanced. So here's the first results of our IPTW weighted vaccine effectiveness. Throughout these slides, you can see the results of the primary analysis on the left, and all medically diagnosed measures of vaccine effectiveness will be in red, and hospitalized ED diagnosed vaccine COVID-19 will be in green. So we can see here that the vaccine effectiveness for medically diagnosed COVID-19 was 35%, and that the hospitalized diagnosed COVID-19 was 55%. And after adjusting for exposure misclassification, the vaccine effectiveness was approximately 4 to 13 percentage points higher. Here's our results stratified by age categories. You can see here that compared to those ages 12 to 17, those ages 5 to 11 had much lower vaccine effectiveness for both outcomes. And here are the results stratified by variant era. We can see here that the confidence intervals for the hospitalized ED diagnosed vaccine effectiveness are very large, and that's due to the low number of hospitalized cases in each exposure group. If we looked at the medically diagnosed COVID-19, we can see that the vaccine effectiveness is much lower during the Omicron eras compared to the pre-Delta and Delta eras. One of the main limitations of the study is that we didn't have any lab tests to define COVID-19, so we had to rely on claims-based diagnoses. And although we know that these diagnosis codes have reasonable validity for hospitalized cases, we know many COVID-19 cases are not diagnosed in a healthcare setting. We are also unable to stratify simultaneously by age group and variant era as we would have liked. And this is due to the stage authorizations by age, as only children ages 16 to 17 were authorized for the vaccines during the pre-Delta era, and children 5 to 11 were only authorized halfway through the Delta era. In conclusions, the estimates of vaccine effectiveness in this study are lower than some of the published estimates early in the pandemic, but there's still a global health benefit to having children vaccinated. And estimates in this study were higher for hospitalized ED COVID-19 compared to medical COVID-19, higher for individuals aged 12 to 17 compared to those 5 to 11, and lower during the Omicron era compared to the pre-Delta and Delta eras. I want to acknowledge all of the co-authors that were involved in this very large study, and I'm happy to take any questions at this time.
We have 3 minutes for questions.
Hi, Nikki Klein, Kaiser Permanente. Thank you for that. I'm just curious, did I miss it? Did you show like the mean or median time since vaccination for these events, or do you have a sense of how much time and whether there's waning in terms of from the last dose?
In terms of follow-up time, or?
Right. So the time from vaccination to event in terms of, because we know there's a big drop off in the vaccine effectiveness over time. And I guess this is after the second dose. So I'm just wondering if you have
Yeah, I
that
know
data.
the largest amount of follow-up time at the end of the range was about 529 days, and that the follow-up time was a lot shorter in the unvaccinated group compared to the vaccinated group. You raise a good point about examining vaccine effectiveness over time, and that's something that we're doing in the adult study.
Thank you, Hector Isurieta, FDA. Very nice presentation. One comment and one question. When you talk about the Omicron era, it's Omicron BA.1.2 era does not include BA.4.5, which has even lower immunogenicity, apparently. The second question is, did you have the opportunity to include some information on hybrid immunity, the combined effect of prior infection and prior vaccination, ideally within the 6 months prior? Thank you.
Yeah, so we removed patients who had a diagnosis of COVID-19 in the 30 days prior to the time zero, the date of the first dose, but we didn't do anything else. Can you repeat what your first part of the question was? You can. Yeah, I can hear you from here.
Also a prior infection that hybrid immunity, particularly the last immunizing event, whether vaccine or infection happened in the last 6 weeks. We are talking about effectiveness against medically attended outcomes of hospitalization, effectiveness hybrid.
Right. Yeah. No, yeah, again, that's a very good point. We're relying on claims-based diagnoses in this study, and so we didn't have any measures of the lab tests, but that's certainly something we could examine. That's a good point.
Hi, Morgan Marks, Moderna. I just had a quick question. I probably missed it. Did you apply a washout period following vaccination for when you start assessing outcomes, typically 7 days or 2 weeks?
No.
And I'm just curious, what was the rationale for?
So we did use I didn't have time to go through the results, but we did look at a negative control analysis in the first 14 days. So that was kind of our way of examining that.
And were there a number of outcomes during that period?
They're really, I mean, there wasn't enough to determine anything for the hospitalized diagnoses. That's part of the problem. The sample size was so small.
Thank you, Rachel.
Thank you.
Great. Our next presenter will be Caroline Corvus from the White River Junction VA Medical Center in the U.S.
Thanks for the introduction. The title of my talk is The Short-Term Effectiveness of Bivalent COVID mRNA Booster Vaccination in the Veteran Health Administration using Self-Controlled Risk Interval Analysis and a Test-Negative Case Control Design. These are my disclosures, and I'd like to first acknowledge my collaborators at the VA and at the FDA and the co-authors on my study. As far as way of background, prior investigations, including our own studies, use the self-controlled risk interval design to evaluate the effectiveness of monovalent mRNA COVID booster vaccination against medically attended disease during periods that were dominated by the Delta variant and the Omicron BA.1 variant. And we also used, as other investigators did, the test negative design. For this particular study, we were interested in using the electronic health records at the VA to examine the short-term relative vaccine effectiveness of the bivalent booster dose during the time of September to November 2022, when BA.4 and BA.5 were the dominant variants in circulation. And we were interested in answering this question by using two different methodologies, one being the self-controlled risk interval design and the other being a test negative design. So this diagram depicts the study framework that we used for the self-controlled risk interval study. And for a self-controlled study, we obviously choose individuals who had the event of interest during a predefined interval of interest. So in our particular study, the outcome of interest is being COVID positive. We were able to identify this in the records according to whether or not somebody had a positive test for COVID or if they had an indication of having started treatment for an infection. And we took individuals who we knew to be vaccinated with the bivalent COVID booster vaccine. And by identifying individuals who were identified as COVID positive on days 4 to 7 post-vaccination, we were able to assume that they likely had their infection approximately 3 to 4 days prior. So after the bivalent vaccination, but during the time at which there would be no immune response yet. And then looking further down the timeline by identifying those cases that occurred in what we call the booster window at days 14 to 7, we assume that those individuals were infected again about 3 to 4 days prior, but that infection occurred during a period at which we would assume that the immune response to the bivalent vaccination had occurred. So we took these cases in these two intervals of interest, the control window and the booster window. And from that, we formed our data set for analysis. So each case was identified as either being a case in the booster window or the control window. And then we used the logistic regression equation shown here to estimate the relative risk. And from that, we determined the relative vaccine effectiveness of the booster versus prior vaccination. For the second analytic approach, we use the test negative design. And for that, we defined our study population according to the study criteria shown here. And again, we were interested in looking at those who were tested for COVID during the variant BA.4/5 predominant period of September to November 2022. And we, of course, restricted this to those individuals who presented to the VA for testing. We identified those as cases, those who had a positive test, and those controls as those with a negative test. And we matched individuals based on the HHS region and the test date. And then among those cases and controls, we determined whether or not they had a bivalent booster vaccination, or whether or not they had no record of bivalent booster vaccination, but did have evidence of prior vaccination. And so taking this sample, we conducted a conditional logistic regression model and adjusted for additional potential confounders in addition to those upon which we matched on. And from that, we were able to estimate the relative vaccine effectiveness. So looking at the results from the first analysis, so this is from the self-controlled risk interval design, we identified 76 cases that occurred in the booster window, and then 95 that occurred in the control window. And the relative vaccine effectiveness was estimated to be 20% with quite a large confidence interval, including the null value. We did do some sensitivities on these analyses, as you can see here, varying the booster exposure period and also some other variations in our assumptions, but it didn't appreciably change the relative vaccine effectiveness. For the test negative design, we identified about 4,500 cases, and we estimated a relative vaccine effectiveness of 56% with a more narrow confidence interval, not including the null value. And we did do some subgroup analyses and did look at stratification by time since prior vaccination, and found that with increasing time since prior vaccination, there was a higher relative vaccine effectiveness. So one of the motivations for doing the self-controlled design, of course, is that we implicitly adjust for time-fixed confounders. And this includes history of COVID for the individual, as well as for waning immunity from prior vaccination. And these can be things that are difficult to measure in a lot of databases. So that's one of the advantages for using a self-controlled design. Also, by minimizing the time between our control and booster window, we were able to minimize the likelihood of time-varying confounding that might be due to different circulation of the virus at different time periods. There are, of course, some limitations to this, one of them being that we use the visit test date as a surrogate for disease onset date. And this could potentially introduce bias if the test date followed the disease onset date by a long period of time. And therefore, we would identify the infection occurring at a certain time, but it actually might have occurred earlier. And this could have potentially biased the results against the booster vaccine. In this particular analysis, the study windows were quite short and the study period was limited just to wanting to look at the period of these particular variants circulating. In future analyses, we could extend the booster exposure window and of course adjust for this with an offset term in the model. And we could also extend the model to look at not just short-term effectiveness, but effectiveness further out in that timeline post-vaccination. And this approach would allow us to do that by adjusting for changes in viral circulation by including an offset term in the model for that as well. The test negative design obviously has, and it has the advantage of including individuals who seek healthcare in similar ways. But there might actually be differences between individuals who are boosted and not boosted that relate to whether or not they are detected as being positive or negative in this analysis. This current analysis did not account for prior infection in that population or the timing of prior infection, and that's something we would like to do in the future to look at individuals who had prior infection and at what wave of the epidemic they were infected. Another limitation of this analysis is that we assume that if there was no record of bivalent vaccination in our data, that the individual did not have a bivalent vaccination. So looking to the future, one of the things that we hope to do is to do a medical record review to investigate this issue of whether or not the case onset date is reflected in the test date that we used in our analysis, and whether or not there might be some bias bias introduced by our assumptions. And for the future test negative designs, to look at severe outcomes and also to use negative controls in our analyses. So thank you for coming to my talk, and I'm happy to answer any questions.
Kevin Haynes, Johnson & Johnson, great presentation. I thought, though, that with the IIS data, that the VA data would be pretty complete with the outside. So if people got vaccinated at CVS, would the VA know about it because of the IIS data?
Yeah, I think, that's a good question as far as the completeness of the vaccination. I think that, there's always a question about completeness of vaccination of data, and we certainly do have some updates of that. I think, in terms of thinking about databases in general, there's obviously, certain data sources that have that absence of record because of people seeking care in multiple places. But I think that within the VA, there is obviously some collection of data from outside sources where that likelihood is minimized. Yeah.
Hi, Bradley Layton, RTI Health Solutions. The numbers went by pretty quickly, but I was struck by the difference in the estimates for the immunocompromised subgroup. That's the only one I really noticed between the two studies. There was essentially 0 in the SCRI, but pretty consistent with all of the others in the test negative design. Just any thoughts on why there's such different results between the two studies?
Right. So for this one, for the test negative design, it was 51% effectiveness, and see, for this one, 4%. Yeah, I mean, I think we're obviously limited with this with the power, and we had a very wide confidence interval on this one from -65 to 44%. Yeah, as far as what's driving that, I'm not entirely sure, but I think our ability to look at it with this sample was small. Yeah.
Hi, Nikki Klein, Northern California Cancer. Very nice. Thank you for this. And thank you for doing this comparison of different methods. I think it's really helpful and actually really informative. I'm just wondering, for your test negative, I may have missed that. What was the time since booster dose in terms of when the analysis was done?
So you mean the
Post-vaccination time and when you're looking at for the period of risk after vaccine,
right?
After bivalent.
So everyone who was included in this study was identified in September to November of 2022. So it's probably a short time from that, because the bivalent booster would have been introduced within a short. So it was a short-term effectiveness. Yeah.
Hi, this is Husseini from Kaiser Northern California. So nice presentation. I'm wondering, the method might apply with self-control risk interval might apply for the booster. Have you thought about applying this method in like in the primary series? Is it possible, or how can you generalize it to other vaccine where there's no booster?
Yeah, so as far as this method we ourselves used for looking at the monovalent booster and for the bivalent booster, but I don't see why you couldn't use it for applications of other vaccines. It certainly could have been used for the monovalent. We haven't looked back at historical data to do that, but I don't think there's a reason why it couldn't be. Yeah.
Yeah. Thank you for the wonderful presentation. You use different methods at the baseline to confirm the cases. Do you think there might be misclassification at the baseline?
Do you mean as far as how we identified cases for
at the baseline,
two different studies?
Yeah.
Right. So we did identify cases for the self-controlled study, those either who had tested positive or who came to the VA to get treatment. And obviously in the test negative design, we had to restrict it to those who sought testing. So we didn't include those who were identified as cases because of treatment. But we did do some sensitivity analyses restricting the self-control method to those who tested positive, so not those who presented for treatment. And it didn't shift our relative vaccine effectiveness estimate too much.
Sorry. My question is that there are two different methods of testing that you use at the baseline. There are two methods for case detection that you use at the baseline. Do you think this may misclassify the cases like a false positive.
Yeah, I'm not sure I understand. So two methods at the baseline?
If you look at the case negative design at
Yes.
the baseline,
Mhm,
to detect your cases, whether the patient is positive or negative,
mhm.
there are two different methods to use. And they have two different, the accuracy, they are not the same. That is
Yeah.
you get what I'm saying?
Yeah, I'm not quite sure I understand, but for the test negative design? Yeah, so those who were cases were those who presented for testing who were positive, and those who were identified as controls are those who presented for testing who were tested negative. I'm sorry, I might not be understanding, but I'm happy to follow up with you.
Thank you very much, Caroline,
Thanks.
and thanks for the questions.
Next, we have Lisa Lundberg presenting COVID-19 vaccine effectiveness against post-COVID-19 condition, a register-based cohort study among 589,722 individuals in Sweden.
Yes, hi, my name is Lisa Lundberg, and I am a clinical pharmacologist at the Sahlgrenska University Hospital in Gothenburg, Sweden, and I'm also a PhD student at the University of Gothenburg. Firstly, I'd like to thank the committee for giving me the opportunity to come here and present our work here today. And the project that I'm going to be presenting is the COVID-19 vaccine effectiveness against post-COVID-19 condition, a register-based cohort study among 589,722 individuals in Sweden. See here. And how do you change the push down maybe? Yeah. No. No, it didn't want to. Let's see here. Yeah, and here you can see our findings and disclosures. In January 2020, SARS-CoV-2 and COVID-19 started spreading, and on the 11th of March, WHO declared a global pandemic. And already during the early spring of 2020, the reports starting to emerge regarding individuals who were suffering from prolonged symptoms of their COVID-19 infection. And in September, WHO took forward a new diagnosis code, ICD-10 diagnosis code, U09.9, for post-COVID-19 condition. And this code has been in use in Sweden since October 2020. And then in late December 2020, the first COVID-19 vaccines were given in Sweden. And by then we'd seen studies showing good efficacy towards the infection. And later on, we've also seen studies showing good effectiveness towards COVID-19. However, the less is known when it comes to the COVID-19 vaccines potential protective effect against post-COVID-19 conditions. So our aim with this study was to investigate the effectiveness of COVID-19 vaccines against post-COVID-19 condition among individuals vaccinated prior to COVID-19 infection using real-world data. And we hypothesized that individuals that were vaccinated prior to their infection were less likely to receive a clinical diagnosis of post-COVID-19 condition compared to individuals who were not vaccinated prior to their infection. And we conducted a population-based cohort study, and we're part of the SciFi-Pearl project, which is a nationwide multi-register linked observational study of the COVID-19 pandemic in Sweden. So through SciFi-Pearl, we had access to several different registers, both regional and national health registers, for example. And by using the personal identity number, we were able to retrieve information from all the different registers and combine them and link them together and use them in our study. So we had access to register data on all residents in Region Stockholm and Region Västra Götaland, which are the two largest regions in Sweden, covering approximately 40% of the entire Swedish population. And in this population, we chose to include all individuals from 18 years and above who had their first registered COVID-19 infection during the inclusion period. And our inclusion period started on the 27th of December 2020, which was the date when the first COVID-19 vaccine dose was given in Sweden, and ended on the 9th of February 2022, which was the day when the large full-scale testing for SARS-CoV-2 ended in Sweden. So that's when we had quite a big change in the recommendations for testing. And the COVID-19 infection was defined as the ICD-10 code for COVID-19, UO 7.1 or 0.2, or a positive SARS-CoV-2 PCR test results. And the ICD-10 codes were retrieved from specialist inpatient and outpatient, as well as primary care data. So we used both regional and national registers for this. So if an individual went to either primary care or specialist healthcare and got diagnosed with COVID, they would get this diagnosis code, and we would see that in these registers. And the PCR test results were taken from the National Register of Notifiable Diseases, which is a national register. And COVID-19 is one of the contagious diseases that we are following in Sweden. So it's mandatory by law to report it. So all the positive PCR test results would be reported into this register. In total, the study population consisted of 589,722 individuals. So the exposure of the study was having received a COVID-19 vaccine prior to the infection with any of the available COVID-19 vaccines in Sweden. And this information was retrieved from the National Vaccination Register. And just like the COVID-19 infection, it was mandatory and regulated by law to report all COVID-19 vaccines given in Sweden into this register. And the outcome was post-COVID-19 condition, which we defined as the ICD-10 code UO 9.9, given after 28 days after the COVID-19 infection. And here we took the ICD-10 codes from the same register, so both both primary care and specialist healthcare. And the reason that we put 28 days as a requirement was that we considered it to be most likely a misclassification if an individual had received this diagnosis code within 28 days from the infection. Because then we thought that it was more likely that that individual, the symptoms that they had was more likely connected to the acute infection rather than to the post-COVID-19 condition. So each individual was followed from their infection, starting 28 days after the infection and up until the first of the following events: vaccination, reinfection, post-COVID-19 condition, immigration, death, or end of follow-up, which was the 30th of November, 2022. And I should also say that if an individual had a vaccination, if they emigrated or died within these 28 days, they were excluded from the study. So in total, there were 299,692 individuals who had been vaccinated prior to their infection. And as you can see, it was mostly common to have received 2 or 3 doses prior to their infection. It was not that common at all to have 4 or 5 doses. Only 88 individuals had that, and 7% had received 1 dose only. And of the vaccinated individuals, there were 0.4% who had received a clinical diagnosis of post-COVID-19 condition. And this is compared to the unvaccinated group, where the same number was 1.4%. We then used Cox proportional hazard regression models to retrieve hazard ratios, which we used to estimate the vaccine effectiveness towards the post-COVID-19 condition. And to get the vaccine effectiveness, we did 1 minus the hazard ratios and then times 100 to express it in percentages. And we had 3 different models. We had a crude model where we made no adjustments. We had a partly adjusted model where we adjusted for age, sex, and period of dominant virus variant at the time of infection. And then a fully adjusted model where we, in addition to adjust for age, sex, and period of dominant virus variant, we also adjusted for comorbidities, which were diabetes and broad categories of cardiovascular, respiratory, and psychiatric disease. And these comorbidities were also defined by ICD-10 codes taken from both primary healthcare and specialist healthcare. And then we had education level, employment status, and region of birth. So in the main analysis, where we looked at any vaccination given prior to infection, that is at least 1 dose, we got with a fully adjusted model and hazard ratio of 0.43, which then again gave us a vaccine effectiveness of 57%. So that was for at least 1 dose given prior to infection. And then we went further and did separate stratified analysis, looking at the different amount of doses prior to infection. So we had 1 dose, 2 doses, or 3 or more doses. And keep in mind that the 3 or more doses are mainly made up by 3 doses, because there were only 88 individuals who had more than that. And then we can see that the vaccine effectiveness increased with an increasing number of doses given prior to infection, with 20% effectiveness for 1 dose and up till 72% effectiveness for 3 or more doses. So in conclusion, with this study, we have shown an association between vaccination prior to COVID-19 infection and a reduced risk of receiving a diagnosis of post-COVID-19 condition. with a vaccine effectiveness of 57% for at least one dose given prior to infection. And we've also shown that the vaccine effectiveness increased with an increasing number of vaccine doses given prior to infection, with a vaccine effectiveness ranging from 20% for one dose and up to 72% for 3 or more doses. And finally, I'd like to thank all my co-authors all the co-authors in this study, and thank you all for listening to this presentation. I think you can, yes.
Thank you. Danny Peter Hammer, University of Oxford. Beautiful data and a very good presentation.
Thank you.
This condition that you call post-COVID condition, I think you call it.
Yeah, post-COVID-19 condition.
Yeah, and you know, it's got a number of different definitions. Wherever you look is different. Did you have the opportunity to potentially explore a little bit, characterize the people that have that condition in your data and see what makes them different? Do they have recording of any of the WHO symptoms? Is this defined by, I don't know, venous thromboembolism after COVID? Do you know a little bit what clinicians are recording when they record that condition? Because this is not like MI, this is completely new, right?
Yes.
And I think beyond the data that you presented, it would be really nice to use this to also characterize that condition a little better.
I mean, using this as an outcome is one of the limitations, I would say, because it is difficult and it's quite wide, and it's been in use since October 2020, as I said. And then the National Board of Health and Welfare in Sweden encouraged doctors to use it when they had a patient who had a symptom that they assessed belonged to the acute infection. And they, unfortunately, are quite vague when they talk about it, because they don't say how long time should pass before you could put the diagnosis or how long the patient should have the symptoms. We demanded 28 days here, and then we did a sensitivity analysis with 90 days, which didn't really change the results. But yes, it is difficult, and it's also, I mean, you could add in some other diagnosis codes, of course, and see which codes have they put together with this code to see, and divide them into more groups and things, which is definitely something that you could do in the future, I think.
Thank you.
Hi. Oh, sorry, it sounded really loud. Suzanne Landy from Pfizer. Thank you so much for this nice presentation. I was just curious if you were able to quantify or examine the impact of any treatments received for COVID-19 to see if that had any impact on the post-COVID condition.
So the treatments during the acute infection, you mean?
Yes.
We have not looked into that. That was a good point, but we haven't taken that into account. But we do know. We've done a previous study on the same group, looking at the people where they were diagnosed, and let's see, most of them have got the diagnosis in the primary healthcare, over 85%, I think, and we also know that most of them have not been in hospital. So it's more common. It's more common to get the disease if you've been in ICU, for example. Then it's around 35%, I think it was. But in total, it was around 2% who got the PCC diagnosis. So the main part have not been hospitalized and then they haven't got treatment, but we haven't taken into account the treatments. Okay.
Thank you.
Yes.
Hi, Hussein Izerbo, Kaiser Permanente, Northern California. Nice presentation. I know you adjusted for age,
Yes.
but I don't know if, I don't think I capture the age distribution that you had in your sample. And have you thought about doing effect modification by age categories?
Well, we have adjusted by age because the rollout is, so this is more a study of the whole rollout of the vaccinations in Sweden, basically. And it was rolled out in 4 consecutive stages where they looked basically on age and risk groups. So it is very dependent on the age and on the risk factors, for example, if they got it. So we have adjusted for that. I'm not sure now if I replied to your question. But yes, please do.
We have 1 minute left, so last question.
Sure. Thank you. Very nice presentation.
Thank you.
My name is Sophie Mayer from Harvard Pilgrim Healthcare. I was curious if you could clarify what you used for time zero or the start of follow-up in your study, and how the choice to condition on having a COVID infection might have changed the interpretation of your results, for example, as compared to just looking at vaccinated and unvaccinated who may or may not have had COVID throughout follow-up.
The first thing was that we started follow-up 28 days after the COVID-19 infection. And that was the second thing you asked. And
I guess, how should we think about the fact that everyone in this population may have had COVID, and how that may impact how we think about vaccine effectiveness in this case?
so I'll try to answer, but what we did was that we wanted to have the first registered COVID-19 infections. We started in December 2020. So if anyone had a registered COVID-19 infection before that, they were excluded. But of course, there can always be someone that has had it beforehand and haven't got tested, but we don't know that.
Thank you.
Yes, thank you.
Great. Our next presenter will be Suno Bae from the School of Pharmacy in Suwon, South Korea.
Thank you. Am I good to go? Good afternoon. My name is Sung-ho Bae from Sungkyunkwan University of South Korea. It's a great honor for me to present ICPE 2023 Halifax. I'm going to present about risk of breakthrough SARS-CoV-2 infection and clinical outcomes among patients with type 2 diabetes. Sorry, there's some technical difficulties.
Different percent.
Oh, really? So, yeah,
Try the slideshow presentation. There's a menu.
Right.
Not menu. Or our tech person. There. Do we have our tech person in the room?
Yeah.
What are you trying to do?
So yeah, I try to do the slides, but it doesn't go the next one. It doesn't change.
The
Here,
screen,
yeah, the screen.
the laptop are showing the same.
I just don't know what. No, it's- No, I better get somebody else.
Oh, there you go. Thank you for your comments. Anyway, again, yeah, I'm going to present about risk of breakthrough SARS-CoV-2 infection after COVID-19 vaccination. So before move further, I'd like to inform you this study was published in Diabetes, Obesity, and Metabolism with same title. And start from backgrounds. Vaccination is known to be the most effective medical intervention to control pandemic situations. And as a result, mass vaccination programs were conducted against SARS-CoV-2. However, breakthrough cases are increasing with the emergence of SARS-CoV-2 variants and the reduction of COVID-19 antigens over time after vaccinations. And breakthrough infections are developing into serious public health concerns and may also lead to questions about the effectiveness of the vaccines, which raises concerns about the vaccine hesitancy. Meanwhile, patients with type 2 diabetes are more vulnerable to infections, likely due to an attenuated immune system. And also, patients with type 2 diabetes had a lower COVID-19 antibody concentration following vaccination compared with the general populations. So taken together, patients with type 2 diabetes are more vulnerable to COVID-19 breakthrough infection and worse prognosis due to COVID-19. So objective of our study was to investigate the risk of breakthrough infection among patients with type 2 diabetes and the risk of severe clinical outcomes after SARS-CoV-2 infection according to vaccination status. We use a large nationwide linked database of Korean SARS-CoV-2 infection registry and COVID-19 vaccine registry, and lastly, the nationwide claims data between 2018 and 2021. The SARS-CoV-2 registry includes RT-PCR confirmed SARS-CoV-2 infection status, and the COVID-19 vaccination registry includes individual level data on vaccination information, including vaccine type, vaccine frequency, vaccinated institute, and vaccination dates. So primary cohort consisted of fully vaccinated population aged 12 years or older, so-called full vaccination cohort. So we excluded patients who had history of SARS-CoV-2 infection before the full vaccinations or heterogeneous or bivalent vaccination, COVID-19 vaccination. Then the primary cohort was divided into fully vaccinated patients with type 2 diabetes versus without type 2 diabetes. Here's the secondary cohorts called type 2 diabetes cohorts, since it is comprised of type 2 diabetes patients with SARS-CoV-2 infections who aged 12 years or older. In this cohort, we excluded patients with SARS-CoV-2 infection before the first diagnosis of type 2 diabetes. Then secondary cohort was divided into fully vaccinated patients versus unvaccinated patients. Again, exposure was full vaccination, which is at least 14 days after receiving scheduled COVID-19 vaccination. Outcome of primary analysis was breakthrough infection within full vaccination cohorts. And outcomes, so patients were followed from the date of full vaccination, which is index date, until the date of breakthrough infections, death, or end of study date, whichever came first. Outcome for the secondary analysis was severe COVID-19 outcomes, which is all-cause mortality, ICU admission, mechanical ventilation use, and hospitalization for any cause within type 2 diabetes cohorts. So patients were followed the confirmed date of SARS-CoV-2 infection until the outcome occurrence, that's 30 days of follow-up and end of study period. Covariates were assessed 1 year before index dates of each cohort. Potential confounders included were demographic, healthcare utilization, diabetic-related medications, comorbidities, co-medication, and Charles comorbidity index. To achieve baseline balance, we apply one-to-one propensity score matching within full vaccination cohorts. We matched patients with type 2 diabetes versus patients without type 2 diabetes to figure out the risk of breakthrough infections among patients with type 2 diabetes. In the secondary analysis, within type 2 diabetes cohort, we matched patients with fully vaccinated patients versus unvaccinated patients to understand effectiveness of COVID-19 vaccine among patients with type 2 diabetes. Hazard ratio with 95% confidence interval was estimated, and also several subgroup analyses were also conducted. Here's the results. This is baseline characteristic of primary analysis, which is a full vaccinated cohort. And after 1-to-1 PS matching, all covariates were well balanced. So patients with type 2 diabetes shows an increased risk of breakthrough infections compared with those without type 2 diabetes with hazard ratio of 1.10. The increased risk of breakthrough infections was more notable among patients with insulin treatment. And here's a baseline characteristic of secondary analysis and within type 2 diabetes cohorts. And after 1-to-1 PS matching, our covariates were also well balanced. Here shows the result of secondary analysis. The risk for severe COVID-19 outcomes were lower in fully vaccinated patients with type 2 diabetes compared with unvaccinated patients with type 2 diabetes. Here's the discussions. Patients with type 2 diabetes, especially those with advanced stage diabetes, were reported to have impaired response to SARS-CoV-2 vaccination owing to the low immunological response. Although the patients with type 2 diabetes were at increased risk of breakthrough infection, the risk of severe clinical outcomes was significantly low among fully vaccinated patients. However, there are also several limitations exist. Information on immunological response to the vaccine was not available, which could have provided more insightful information of effectiveness of vaccine among this vulnerable population. And secondly, asymptomatic or mild SARS-CoV-2 cases may not have been captured in our database. And lastly, our data period covers the time when the Delta variant became the dominant strain in South Korea. So results of our study may be hard to generalize during the other variant dominant periods. Here's the conclusions. Type 2 diabetes was associated with 10% increased risk of breakthrough infections among fully vaccinated population, while patients with type 2 diabetes remain a vulnerable population to SARS-CoV-2 infections, and even after the full vaccination still associated with a lower risk of severe clinical outcomes after infection. Taken together, these findings demonstrate the potential advantages of COVID-19 vaccines for preventing severe clinical outcomes following SARS-CoV-2 infection, breakthrough infections among patients with type 2 diabetes. Also, results of our study further support the current guideline recommending this vulnerable population as a vaccination priority group. Thank you for your attention.
Yeah, Hector Isurieta, FDA, nice presentation, appreciate. Maybe you have done that, but if not, some of the treatments for diabetes, specifically including metformin, can be effect modifiers on the risk of infection and the risk of severe infection, also on the risk of long COVID, by the way. So it might be interesting to account for that effect modification by stratifying, for instance. We could discuss offline afterwards if needed.
Thank you for your great questions. Yeah, metformin and other diabetes medication could be effects modifier. So we did stratify analysis according to previous use of insulin. However, we didn't conduct the stratified analysis according to metformin. Anyway, thank you for your comments.
If there are no more questions, thank you, Sunho. I think we are right on time.
Our next speaker will have the final two presentations. Frank Xu is first going to present associations between HLA variations, and serologic response to COVID-19 vaccination, an analysis of UK Biobank antibody survey data.
Okay. Hello, everyone. My name is Junqing Xie, or just call me Frank for easy. I studied pharmacoepidemiology at the University of Oxford, and I have just completed my DPhil defense just in last week. In past years, my research experiences has focused on bridging large-scale real-world data and the genetic data to understand the effects of drugs and the vaccines, either their side effects or the effectiveness. In today's presentation, I will walk you through the relationship between the host genetic variation, specifically in human nucleoside antigen, HLA, and the individual response to COVID-19 vaccine. It will consist of two consecutive parts. And in this first part, I will present you a hypothesis-free study where I studied a lot of HLA mutations and the impact on the antibody response to COVID-19 vaccine. In contrast, in the second part, I will just focus on a specific HLA mutations and focus on the impact on the breakthrough infection outcome. My DPhil study was supported by Oxford Clarendon and Jardine Scholarship, and other than this, I have no conflicts of interest to declare. Historically, it is well understood that the adaptive immune response comes from two critical components. One is cellular and another is antibody response. Since the on-market of COVID-19 vaccine, there has been a lot of study conducted ongoing in order to identify the determinants for the vaccine-induced antibody. However, most of these studies were limited to the environmental factors, and until now, there is still a lack of understanding of the genetic role underlying this process. In a recent review, Smati and his colleagues summarized previous evidence on other vaccines, including flu and hepatitis vaccines, and they proposed that the host genetic variations should play a critical role to the antibody response to SARS-CoV-2 vaccine as well. And they think the human nucleoside antigens should be the priority for the future study. Therefore, to fill this knowledge gap, we initiate this study in order to understanding whether and which HLA variations will affect the antibody response to the COVID-19 vaccine. We use the data from UK Biobank, which is a population-based cohort with over 500,000 participants recruited across the UK. It contains comprehensive biomedical information and has been linked to external data sources enable the follow-up of health outcome. And specifically in our study, we used the genotype information and the latest antibody data. This slide shows the diagram of cohort selections. Basically, we included a group of people who has attended the antibody seroprevalence survey and had a valid antibody test. Before the antibody test, we restrict patients who had received at least one dose of vaccine and excluded those who has been previously infected or vaccinated to more than 3 months ago. We used a case control study design as I illustrated in these figures. Basically, we define the cases as those who had a positive antibody test and control as those who has a negative antibody test. Then we look forward backwards to compare the differences of the genetic mutations. Just to highlight that, because all the cases and the controls are identified from the UK Biobank cohort, so more accurately, this is a nested case control study design. The antibody was tested by the two at-home testing device that was designed specifically for research purpose. It is easy to use and can be complete with just 20 millis to get the results. And what is important is that this testing method is quite accurate with the sensitivity and the specificity over the 98% in comparison to the golden standard and ELISA. The genotyping was performed previously using two bespoke array, and the HLA allele was imputed by a mature algorithm. If you are interested in more detail about the genetic procession process, you can always stick to this paper published in Nature for more details. Finally, in our study, we included over 141 alleles that covers 11 genes across the class 1 and class 2 regions. We used the logistic regression model with the binary antibody outcome as the independent variable and accounted for the potential confounders such as age, sex, and ethnicities. Due to we have multiple statistical testing, we use the Buffalo method to correct for the multiple testing issue. Here are the results of the baseline characteristics of our cohort. We can see we included a larger group of people with over 100,000 participants. As you must be aware that UK Biobank is a relatively old cohort. We can see the average age is over than 7 years old. And our cohort has more female than male, and most of the participants comes from the white ethnicity. This slide shows the associations of all the allele with the antibody response. The x-axis is the length of each allele, and the y-axis is the minus log p values. Different color means different HLA genes. In general, we can see, except for the two genes that was not associated with antibody response, all the remaining 9 HLA gene has at least one mutations that are statistically significant associated with the antibody response. This plot shows those 24 significant alleles for the coefficiency. The red color here means the allele that was associated with decreased antibody response, and the blue color means the allele that was associated with increased antibody response. Basically, we can see the number of alleles that associated with increased antibody response were generally equal to the number of alleles that was associated with the reduced antibody response. And we think this can be explained by a genetical principle that the genetic mutation is a random process, so its impact on antibody response should be also random. And among these 24 alleles, most of them haven't been reported before, and the one that has been reported is called DQB16, that recently published in Nature Medicines, and we replicate these findings, and will be the focus of our next presentation. So let's recall our original questions. Whether and which HLA alleles affect the antibody response. And our answer is yes, the HLA allele variations will affect the antibody response. And we identified the 24 alleles across the 9 genes. Our studies benefit from the largest and the most powerful sample size, and is based on a community-based population, which means it has both internal and external validity of our estimates. However, we recognize that most of the participants are relatively old, and we only use the binary antibody response outcome. And most of participants comes from the white ethnicity population. To conclude, I think our study offers comprehensive genetic insight into the antibody response to COVID-19 vaccine and put the way for the personalized vaccination, maybe through the genetic mark in the future. That's all. Thanks for your listening. I'm looking forward to your questions. If no question, I will just follow to the second one.
We'll stay on this one for the next 5 minutes.
Hi, just a quick question. Were you able to look at differences in response by vaccine type, mRNA versus not mRNA?
Yes,
Did you see any differences?
Yes, so about 50% of our participants had the vaccination type information available, and we have conducted that analysis separately, and the results didn't change too much.
Frank, were you able to consider people who are on medications that might affect their immune system and therefore cause them to not have a full response, such as some of the immunosuppressive therapies?
Yeah, that's a good question. I think our focus of this study is just to explore the genetics determinants, whether there was a modification effect by others such as age or the medications is not our primary focus, but it's interesting to study for that. Yeah, thank you.
Frank, thank you. Was there any thought given to looking at antibody response as either something other than binary or doing any sensitivity analysis, looking at the cut points that you used?
Yeah, so this is one of our study limitation because we only have the binary antibody response outcome available. That is test positive or negative, but we know the antibody is a continuous variable, right? We have a threshold.
Great, thank you.
Thank you. Okay, let's move to the next. Okay, it's me again. So I can see there are new people coming, so I feel like I have to reintroduce myself. Hello, everyone. I'm Frank. I'm a DPhil student, but just finished. My research experiences focus on bringing the real-world data and genetic data to study the drugs and vaccines effects. But I mentioned before, my second talks focus on a specific HLA allele, which is called HLA-DQB16. And the outcome we are focused on here is the COVID-19 vaccine effectiveness. More accurately, it is the risk of breakthrough infection outcome. And the reason why we focused on this specific allele is because it was recently reported by a study published in Nature Medicine. And the researcher found that people carrying this specific allele will have increased antibody response, and more importantly, have substantially reduced the risk of breakthrough infection outcome. However, we noticed that this evidence was derived from a group of trial participants, and we know that trial participants are generally more healthy and younger, sometimes richer. So that's a not a representative population. Therefore, we aim to test whether these findings in trials are really replicable and generalizable in real-world settings. We use the data from UK Biobank, as I mentioned before, But what is differently is beyond the genotyping data and antibody data, we added another layer of data that is the COVID-19 infection status, which is obtained through linkage to the national surveillance system at the individual level. Unlike to the case control study to study the outcome of antibody response, in this study, we used a cohort study design and to focus on the risk of breakthrough COVID-19 infection outcome. As depicted in this diagram, we included a group of people who has been vaccinated and group them based on the genetic mutations of this specific allele and follow them until the study end or the occurrence of the breakthrough infection outcome. This slide shows the cohort selection process. Basically, we included all the participants who has the complete genetic data and has a linkage to the primary care record so that we can capture the vaccination status. All participants has been vaccinated with COVID-19 vaccine, and we excluded those who has been previously infected at the index date. That is the date the participant receiving the first dose of COVID vaccine. And the genotyping data, as I described in the last talks, basically it was genotyped by the 2 bespoke array and was imputed by a mature algorithm so that we can get the accurate HLA mutation information. The outcome in this study is the breakthrough infection outcome that was obtained through linkage. And all outcome was PCR confirmed, and we also defined a severe COVID-19 infection outcome, which was those who infected and hospitalized with 13 days of infection. In the cohort study, we used the Cox proportional hazard model because this is the survival data. But we think the confounding structure is similar between the case control and cohort study, and we accounted for them, including age, sex, ethnicity, genetic ancestry, which is measured by the top 10 principal genetic component, and the genotyping, the 2 genotyping array that I mentioned before. In this baseline table, I want to highlight that in the genetic analysis, the confounding is no longer a big issue. As you can tell, when we stratified by the genotyping information, we can see the covariance between the 2 comparison cohorts is highly balanced, even without using any matching method. Because this is genetic mutation is just like a random process. It shouldn't be correlated with a lot of environment covariates. And besides these covariates I present you here, we also tested other chronic conditions and co-medications, all well balanced. These are results of the genetic mutations with antibody response. And we can see that participants with a positive antibody response will have a higher prevalence of this specific HLA allele with an odds ratio larger than 1. This means that these mutations is positively correlated with antibody response, and we confirmed this result is consistent with the one that published in previous study. However, in terms of the association with the breakthrough infection outcome, we can see the cumulative instance curve between the 2 groups are highly overlapped over time. Either for the infection outcome as listed in the right side, and the hospitalization outcome as showed in the right side. The final estimate of hazard ratio is close to 1. And there is no statistical significance. So in summary, whether these findings in trial replicable or generalizable, I think our results has showed partially. In terms of the antibody response outcome, we replicated, but for the breakthrough infection outcome, we didn't. Frankly, we still do not understand exactly what's the potential reason for the sources of heterogeneity or discrepancy between our study and the previous study. But here are several key study elements should be highlighted in order to understand the background. Basically, we can see our study has a much larger sample size compared to the previous study, but that's unlikely to explain the differences. Also, our participants has been vaccinated as a mixed type of vaccine, including the AstraZeneca one and the Pfizer one. But in the previous trial cohort, they're all being vaccinated with AstraZeneca one. More importantly, our population is relatively old, which is 13 years older than the trial participants, and we speculate that could be explain the potential differences due to a well-known phenomena in immunity that is called immunosenescence, which describes that the old people have much less responsive to the external triggers, such as vaccines. Nevertheless, I think this discrepancy should be confirmed by future study. And what we learned from here is always be cautious when extrapolating finding from a single and long representative population, especially for these lower findings. Also, we think the evidence triangulation is quite important, not only across different databases, but also different study design and the data types. We actually have performed several additional analyses in order to get deeper understanding on these research topics. And for example, if one genetic mutation cannot confer the differential risk of breakthrough infection, how about the concurrent mutations across multiple HLA alleles? If you are interested on these results, you can seek our study that has been presented recently in this paper. In this last slide, please allow me to give many thanks to my supervisors and my lovely group members from the University of Oxford. And as all, thanks for your listening. I'm looking forward to questions.
Hi, this is Phoenix from University of Florida. So I have a question that because you had a big sample size, did you consider to replicate or mimic the population in the previous study so that you can have a more direct comparison in the result?
Yeah, that's a good question. The problem is the UK Biobank cohort is relatively old, and the minimal age is 50 years old. So it seems impossible to minimize the trial cohort. But we do stratify it by age and observe this trend with the people getting old, the immune response getting much lower.
Okay. And did you try to restrict the population to AstraZeneca vaccine only or not?
Yeah, we did that, and the result is still the same. So we think the vaccine type cannot explain these differences.
Okay, thank you.
Thank you.
Hi, Frank. I could have missed it, but could you comment as to whether the trial that you are comparing your results to use the same algorithm to attribute the HLA allele status as you were using in your study?
You mean in terms of measuring genetics?
Yes.
Yeah, I think the genetic part always. So in terms of genetic measurements, our algorithm is quite accurate actually, and we can actually compare the prevalence of these specific mutations is highly comparable, both with the prevalence like the 43% in our cohort and in the trial cohort. That means the genetic measurement is not the issues.
Thank you.
Okay.
Any more questions from the audience? If not, thank you very much, Frank.